welcome to the CTN TNI SIG. That's not a mouthful of acronyms. There are none. So CTN Clinical Trials Network, NIDA Clinical Trials Network, TNI Translation and Implementation, and SIG Special Interest Group. Some of you have been with us from the beginning. It may be one of the longest running special interest groups in the history of the CTN, and at different points probably expands to be among the largest. We take that as a good thing and really capitalize on the interest in applying implementation research methods to projects and potentially increase their scalability in routine practice context, which is really, I think, the point in many ways of the CTN, or at least the overarching goal. Today, we actually have a really cool project and a really excellent team of researchers presenting on the CTN 00095. It's really, I found it to be a super ambitious study and a real world study with real world implications. And I'm really excited to hear about the findings. And many of us are interested in some of the implementation implications as well, since this was very, very real world. The leads are Dr. Rebecca Rossom, who's a senior investigator at Health Partners Institute and associate professor at the University of Minnesota Medical School, Department of Psychiatry. Dr. Rossom's a health services researcher and has been involved in clinical decision support tools and systems for many years, not only in the field of addiction, but really as well as other chronic conditions. Dr. Stephanie Hookre is a research investigator also at Health Partners and adjunct assistant professor at the University of Minnesota in the Department of Family Medicine and Community Health in the School of Public Health, and is also an experienced researcher on behavior and psychosocial influences on health. Dr. Gavin Bart is a kind of a leader across the CTN, has been involved in many projects over the years. Leads the North Star node of the Clinical Trials Network and has done a lot of work internationally, globally in the field of addiction and HIV as an internal medicine and addiction medicine physician. And also, I didn't know this, has a PhD in experimental and clinical pharmacology, which is very, very cool. I'm going to turn it over to the presenters. And again, really excited about this project. I think it has a lot of implications for integrating addiction medicine, particularly for people with opioid use disorders in primary care, using technology prompts and clinical decision support. So Dr. Rossom, Dr. Hookre, Dr. Bart, welcome. We're excited that you're with us today.
Great. Thank you so much for having us all, and it's wonderful to see so many familiar names on the list, and to meet some new people on the list. So thank you for joining today. I'm going to start us off, and why don't we just go to the next slide? All research entails very large teams of individuals, and I really want to give the shout out to Rebecca Rossom and the whole Health Partners team, who really took the full lead in this, in building the tool and really designing the study, and working with me, with CTN and EMIS on getting that final protocol and getting this study up and running, and also being a major site for this. And certainly our other healthcare systems, Geisinger in Pennsylvania, Ascension, Northern Minnesota, is providing primary care clinics for the study and partnership with the investigation. Next slide. So as mentioned, the goal of the study was really to identify the utility of a clinical decision support tool embedded into the electronic health record for primary care providers to better address opioid use disorder. Now, the study was initiated and conceptualized prior to the removal of the X waiver. That occurred actually during the course of the study. But I think even before the removal, it was clear that the barriers to prescribing buprenorphine really weren't all knowledge base. Physicians didn't know enough, so we need to have the PCSS or we need to have echoes. Knowledge wasn't really the barrier, and frankly, the X waiver process wasn't necessarily a huge barrier. It seemed to be that systems were bigger barriers. Clinical workflows, system support to be able to address opioid use disorder within the clinic were often cited as the reasons why there wasn't great uptake by primary care providers. There's been a more recent than this 2022 meta-analysis that also supports that it's really systems level issues that are getting in the way of the proliferation of medication prescribing for opioid use disorder in primary care. Next slide. So the question is, could there be an e-solution to help smooth this process over, to make it easier for primary care providers to overcome these system levels? And certainly, we know there are lots of guidelines for treating opioid use disorder. The VA has one, the American Society of Addiction Medicine has one. Their guidelines exist, but very few people truly use them. They're pen and paper, or they're a PDF that people don't have. Some people have developed apps that you could have on your phone that you could kind of toggle along with, and it would walk you through guidelines. But that's really awkward when you're in the midst of seeing a patient then and there, and they are right in front of you. You don't want to toggle between the electronic health record and your phone to figure out what to do next. And even those iPhone kind of apps, they're just walking you through the algorithm. They aren't adapted to the patient you're seeing in front of you, adapting in real time, combing that patient's electronic health record to provide you guideline concordant recommendations based on the knowledge that already may exist within that individual's electronic health record. So the idea was of this study, could we create a clinical decision support tool that is directly integrated into the electronic health record and in real time can direct primary care providers in guideline concordant care for opioid use disorder. And that goes from screening to diagnosis to starting buprenorphine or referring someone to ongoing care, and also addressing some of the medical issues and behavioral issues that would need to occur during the initiation process. Next slide. So we started a long time ago, actually. It was a work group formed by the CTN back in 2016 about whether this could even be possible, and all kinds of guideline-driven, consensus-driven decisions were mapped out into multiple pages of an algorithm that I think ultimately ended up being 20-something pages like this, which if you look at all these decision points, it is absolutely overwhelming. And most people would look at this and say, there's no way you could make this into a real-time, live, interactive algorithm. And really the only way we could get beyond it is by building it. And so part of an earlier CTN study, we actually built the interface that the providers would see and piloted it just to see if it was feasible. Could it be done? Was it usable? Did providers tend to think it was something we could move forward with? And upon some positive indications, the full 92 clinic randomized trial was done, along with some mixed methods input. So with this, I'm going to hand it to my colleague, Dr. Stephanie Hookre, to talk a little bit about the design phase.
All right, thanks, Gavin. So as we were beginning this study, it was really important to us that we got feedback from the end users of our clinical decision support system to really decide, how should we implement this tool? What should be on the tool? And just to make sure that it was acceptable to those users at the end of it. So at the beginning of the study, what we did is we actually interviewed 8 clinicians or leaders. So these were primary care clinicians, both physicians and advanced practice providers who had been part of our pilot. So Gavin mentioned the earlier study where they had built the algorithm in the front end of the tool. And these had been volunteers who were interested in using that tool. And so we asked them their feedback, and I'll get to that in a second. And then the second part is we recruited 20 patients in our system, and these were patients who were high risk of problems with opioids. So they either had opioid use disorder, they were on a MOUD, or they had at least 3 prescriptions for an opioid in the last year. So that was kind of our way of identifying people who might be at high risk for problems at the time. And that shifted in over the course of our trial. So let me tell you what we learned from them and how we use that to design our tool. So as I've mentioned, we first talked to clinicians and leaders who had been using our tool during the pilot. And so the good news from them is that we heard that they thought, yes, we should, as in primary care, it is important for us to address OUD and to treat OUD here. So they thought, yes, this is a good place for us to implement some sort of intervention, which is good if we wanted their buy-in early on, right? But we heard that their relationships with their patients were really important in whether or not they would actually address OUD. So if this was the first time they were going to see a patient in primary care, they would be less likely to bring up opioid use as a potential issue to discuss, especially if it wasn't the primary concern for the patient coming into the clinic. And this is because they were afraid of potentially damaging a relationship by bringing up, potential concerns about opioid use. Conversely, if patients, the clinicians felt like they had a really good relationship with the patient, they would be much more likely to bring up opioid use if they thought it was a topic of concern. So I think that trust and the ongoing relationships in primary care are really important. And so we learned that, they might not address this at every visit, and we definitely more likely to address this with patients that they identify as kind of their own patients or patients they see frequently. Of course, if you do any study in primary care and you don't hear that time and competing priorities are barriers, then you probably didn't get the right questions, because this is something that we hear in every study we do in primary care. And we know that our primary care clinicians, especially in our system, are seeing a new patient every 15 minutes. And that patient that they see doesn't have just one complaint. They might have several things that they want to talk about in those 15 minutes. And often opioid use is not the reason for coming in unless patients are specifically coming in for treatment for opioid use disorder, or they have a pain concern that they want opioids for. So it's very unlikely that the patients we'd be identifying in this intervention would be there specifically for this reason. And so this was really important because the intervention that we had to design had to account for this, because if we added too much time, or we didn't acknowledge there were other things that the clinicians might be doing during this visit, then the clinicians would not use the tool. And the other thing we heard is that each clinician had different needs for a clinical decision support tool. So some clinicians at this time, the X waiver was still in place. So some were actually prescribing buprenorphine frequently and were kind of used to doing that process. And so for them, a tool like this would be helpful for identifying patients who would need additional support or who might need that prescription, but they wouldn't necessarily need to go through all of the steps of like, how do I prescribe, or and go through induction for buprenorphine for these patients if they're pretty familiar with it. Conversely, there were other clinicians in the study who were not X-waivered, so they couldn't actually prescribe buprenorphine at the time. So their reason for using the tool was more of like a screening and referral. So we had to have a tool that was able to adapt to the different needs of the different clinicians in order for it to be useful. And finally, the CDS is only one part of the intervention, remembering that the CDS is embedded within the EHR or within the health system. And so that system must support the use of a tool like this. And in particular, the clinicians were concerned about not having kind of the organizational support for prescribing buprenorphine. For example, if they didn't have another clinician in their clinic who could back them up if they were on vacation, something like that was very a big concern about why maybe some clinicians didn't even want to prescribe buprenorphine in the first place. The other thing is that, patients who had opioid use disorder often have other psychosocial needs, or they have comorbid mental health conditions. And so they wanted to be able to know, what are my resources and support for the patients that I'd be prescribing an MOUD for? Because if they don't have those additional supports, just prescribing that medication is not enough. And so they all of this together kind of made us realize, what are the things we need to have in our CDS, and what do we have to account for when we're thinking about designing a tool like this to be used in primary care. So we also kind of wanted to talk to patients to get their feedback on what they thought tool like this might be useful for. So we talked to 20 patients, and the first thing I will say is because of our inclusion criteria for the trial, we included patients who had already had opioid use disorder diagnosed, and we included patients who we considered high risk for potential problems with opioid use. So this essentially meant that patients coming into the study and into this particular qualitative sample had different relationships with opioids at the beginning. So patients who are aware that they have a diagnosis of opioid use disorder and are on treatment are generally kind of more accepting of being willing to talk about their opioid use disorder with a clinician. Whereas patients who we consider potentially high risk for having opioid use disorder, who had just had maybe an opioid prescription, they were concerned about being potentially labeled as somebody who had an addiction when they didn't feel like that was a problem that they had. So this made us realize that the way we approach this tool with different patients is really important, so that we don't have some patients feel alienated by the language that we're using, or feeling that the clinician doesn't really understand kind of what's happening with them. And kind of the relationship that patients had with opioid coming in really was related to their preferences for how they wanted to talk about this, with whom they wanted to talk about it with, and what terminology to use. So patients who had a diagnosis of opioid use disorder were actually very comfortable with words like addict or addiction. Those are words that kind of resonated with them. Whereas patients who maybe had just an opioid prescription, who had maybe used it after multiple surgeries or something like that, were like, I don't use that word with me. I don't feel comfortable with that word. And so we really had to think about how we framed the messages based on how people were coming into the clinic. Similarly to what we heard from clinicians, our patients also thought primary care was the right place to discuss opioid risk. So I would say, I think it was over 90% of patients said, yeah, I want to talk to my primary care doctor about this. That's the person I feel most comfortable with. There were a few patients who felt like, no, I'd rather talk to a specialist or talk to someone who's prescribing an opioid for me. But in general, patients felt very comfortable talking with their primary care doctor about opioids. The other interesting thing was that we heard mainly from patients who had an existing diagnosis of opioid use disorder, but a little bit from patients who had prescriptions of opioids, was that they had developed a sense of whether or not their clinician was going to be willing to prescribe an opioid to them. So there are some patients that said, I know that this doctor is going to prescribe an opioid if I want it, so that's where I'm going to go here, but I might keep that person separate from my regular care, essentially. So there's a little bit of kind of using the system to get what they wanted out of that, with different patients being willing to talk to some clinicians versus others, essentially. So it also made us realize that sometimes when they're going to see their regular primary care doctor, they might not actually want to talk to that doctor about opioids if they're seeing somebody else for opioid prescriptions. And patients had generally very limited awareness of overdose rescue medications, even patients with existing diagnoses of opioid use disorder. So that was something that we felt like we needed to raise awareness of with patients, that this was something that they should probably carry on hand, especially if they're at higher risk for having an overdose. And as part of our tool, which I think Rebecca will go into a little bit more, is that we print out decision support for both the clinician and the patient. And this is really to get it in front of them, because if it's exclusively in the EHR, often it would get missed. So patients will get a handout, and that handout would be welcome from a clinician. But if they thought the computer was printing out a handout because they identified they are at risk for problems with opioid use, they were a little bit more suspect about that. So we realized that the handouts had to come as part of a conversation with the clinician, and to be able to feel useful to a patient. All right, so we took all of this feedback from clinicians and patients, and this is kind of how we designed our tool. So we first had to make sure we matched the language preferences based on the reasons patients were eligible. So we'll see that there's different messages for patients who had existing opioid use disorder, and there are existing different messages for patients who we identified who had an opioid overdose. There's different messages for patients who just had higher risk for opioid use disorder. So we really tried to make sure we were matching that language so that we didn't have any patients feel alienated or uncomfortable by what we were trying to do in that encounter. The second thing is that we had to keep the tool very simple, but we had more complex decision support for clinicians who needed it. So for clinicians who were newer to prescribing buprenorphine and needed that step-by-step walkthrough about how do I decide for which patient what to prescribe, how much to prescribe, we have that complex decision support. And we also have easy buttons for, like, if you just want to refer a patient to somebody who will do this for you, you can do that too. We always emphasize clinical judgment and supporting the patient relationship. Again, this was very important to the clinicians. And so all of our recommendations say, consider doing this. We don't say, prescribe this, do this. We always say, consider this in light of what you know about this patient and having a conversation that you're, you are in charge of making that decision. And then we also included links to other important resources in the health system when available. So making sure that there was the whole extra page about making sure patients get access to the right resources for mental health conditions and infectious disease care, things like that. So we basically, to wrap it all up, we took all of that information we got and really tried to design a tool that was simple, easy to use, and matched the needs of the clinicians and the patients. I think now I pass it over to Rebecca to talk about the actual tool design and what went into the tool.
Yeah, thanks, Stephanie. Yeah, so I'm going to show you a little bit about what the tool looks like and tell you a little bit about study results, and then pass it back to Stephanie, who's going to talk more about some of the mixed methods work that we did while the study was ongoing. So this is an example of what the clinician printout looks like. This is integrated with other clinical domains that we have running on this platform that we call Wizard. A lot of it's focused on cardiovascular risk reduction. But we decided early on that if somebody met criteria for Opioid Wizard displaying, that would be their highest rated priority. So you can see for this person, they have an existing diagnosis of opioid use disorder, but it's not on the problem list. They haven't been prescribed naloxone, and they haven't been prescribed a medication for OUD. So those are the things we want to get on that clinician's radar. We also let them know about any medications that the patient's on that may increase their risk for adverse outcomes. This person's on a benzo. We know when they're also on opioids, that can be a dangerous combination. And then this is an example of what the printout looks like, but this page is also available in Epic in the EHR. So where you see quick actions to consider, the rescue kit referral, there's some other ones there. Anything you see in what I'm showing you that looks like a hyperlink can generate an order that populates into Epic for clinicians to review, edit, and sign just like any other orders. So they could do that here as well. Next slide, please. This is an example of the patient printout. It's less reliant on literacy and numeracy. We spent a lot of time debating what these patient messages should look like. And as Stephanie mentioned, they differ depending on the reason the patient is qualifying for this to display. Ultimately, knowing that the EHR is far from infallible, we didn't want to say, hey, we think you have opioid use disorder. What we really wanted to communicate to that patient is this is the right place to seek care if you're having trouble with opioids. And so a lot of the messages are more around, if you have concern about opioid use for you or your family, talk to your clinician, and just giving them the message, the door is open. Maybe this isn't the encounter where they decide to bring that up. Maybe it's the next encounter. But it was important for us to not alienate patients and give them that message. Next slide, please. Okay, and so this is what it looks like in Epic. So if the clinician clicks into the Wizard tool that's available in Epic and goes over to that Opioid Wizard tab, there's a lot of functionality available here for them. What we heard when we met with clinicians early on is, tell us why this is displaying for this patient. We want to know. So you see that sort of at the top there. This patient's qualified because they have estimated high opioid use disorder risk. We summarize relevant conditions. This person seems to have active depression based on their most recent PHQ-9 score. And then you see quick actions there. Again, pretty prominent location on this clinical decision support tool, because some of the clinicians said, look, I'm going to be honest with you. I think this is important, but I'm never going to prescribe these medications. Make it easy for me to get these folks connected with treatment. So there's they can order naloxone. They can refer to at the time, wavered primary care colleagues when that was no longer needed, to primary care colleagues who indicated an interest in treating opioid use disorder, or to specialty care. That button in the middle there, we can port them directly into the PDMP with no additional logins needed, trying to remove some of those barriers. And we summarize the OUD tox screen there on the right. On the top right there, that suggestions button is pretty important. We tell clinicians as we train them, if anything doesn't look right to you, if you disagree with the decision support, if we're not picking up something that we should, click on that button. It generates an email to me and my team so we can review that patient at that encounter and figure out what's going on. And then the bottom half of the screen there, it gets into more of sort of the meat of the tool. So we sort of walk clinicians through diagnosing, selecting a medication, more details on prescribing Suboxone and other care. We were using the opioid and heroin pieces of the TAPS tool for screening, and if that's positive, we bring them to the full DSM criteria that we've embedded as a smart form in Epic. And then on the right-hand side there, you see that green circle. We call that our note builder. Clinicians were like, okay, you had me do all this stuff and click around and, I've provided all this care for the patient. Make it easy for me to put it in my note. So this tool collects all those clicks, anything that they've entered, positive TAPS, positive DSM, summarizes it there, and then they can cut and paste that into their progress note. Next slide. This gives you a sense of what we're offering to help patients and clinicians consider medications for opioid use disorder. The top right-hand side there, the OUD medication overview, is a one-pager that helps patients understand the main differences between Suboxone, IM, naltrexone, and methadone. Not just information about the medication specifically, but where they're available and how they take them. We also have a handout for each of those medications for opioid use disorder, one on naloxone and one on safer use of IV drugs. Under treatment selection, then, you'll see those radio buttons are pre-populated from information we can gather from the electronic health record. But again, the clinician may know something that's not yet in Epic, and so the clinician can override any of those radio buttons if they have updated information. This person doesn't have any relative contraindications to any of the moods, so they're eligible for any of these. But on the next slide, you'll see, like, if somebody, for example, has severe liver disease. Can you go to the next slide, Stephanie? Yeah, then the decision support changes. In our health system and the others in this study, we decided that if somebody has severe liver disease, they're probably not appropriate for primary care treatment of OUD, and we want to get them over to specialty care or to a methadone clinic. Next slide, please. Okay, and then this kind of gets into the meat of guiding clinicians on starting Suboxone, because we heard in our interviews they just felt like this was a more complicated medication than many of the other ones they prescribe, and they're right. And so we offer guidance for both at-home and in-clinic induction for Suboxone. The vast majority of our clinicians are doing at-home induction. We gave them 3 potential starting doses that primary care chose, 2, 4, or 8 milligrams, and induction instructions for the patient that I'll show you in a sec. And again, any of those hyperlinks generate orders into Epic, so they can order their Suboxone rescue kit, baseline liver function tests, clonidine and Zofran, and refer them for therapy. They can also print a SOUS if patients want a little more guidance about when to start their Suboxone. There's another tab for Suboxone maintenance that I'm just not going to go through in the interest of time, but really kind of guides clinicians on what questions to ask when the patient comes back and how to adjust the medication. Sorry, Stephanie.
Okay.
And then this is an example of a handout. This happens to be for starting Suboxone at 4 milligrams a day. It's pretty detailed, and it's meant to really walk patients through how to take this. So, coaching them that you have to be in withdrawal before you take this medication. Here's what we mean by withdrawal. You need at least 3 of these symptoms. Here's how you take it. Then you wait 1 to 3 hours. How do you feel? If you feel lousy, you can take another dose. If you feel okay, hang tight, and kind of trying to minimize the back and forth between patients and clinicians, and minimize some of the clinician burden with this. And we've got 3 of these tailored to those 3 starting doses. Next slide. Okay, so then we get to figure out whether this thing worked. And so we did a randomized clinic, cluster randomized by clinic, 92 primary care clinics across 3 health systems. That really was implementing this tool. The tool is actually implemented in all 92 primary care clinics, but for half of those clinics, it just operates in the background and collects information that we need for analysis. And then in the intervention clinics, it displays and has that full functionality that we just showed you. Next slide, please. So our aims were to look at our impact on diagnosis of opioid use disorder, naloxone orders, treatment for opioid use disorder, either starting a patient on a medication for OUD or referring them to start a medication for OUD. All of those were within 30 days of a patient's index visit. So the first time they're coming to a primary care visit and they're eligible for the intervention. We also looked at days covered by a medication for opioid use disorder in the 90 days after index. So patients were eligible if they were between 18 and 75, and then they either had a diagnosis of opioid use disorder, they had an opioid overdose in the prior 6 months. So we looked for ICD-10 diagnoses. We also looked for days when they were administered naloxone on a day they didn't also have facility administered opioids, so that we weren't catching everybody's endoscopies. Or they had estimated high risk of opioid use disorder or overdose. That's using an EPIC risk equation that EPIC's made available. We didn't present the decision support if somebody was on active chemotherapy, if they had stage 4 cancer, if they were enrolled in hospice or palliative care. We went live in April of 2021. We're supposed to go live in April of 2020. That didn't pan out so well. So April 2021, February 2022, April of 2022. We accrued patients through the end of calendar year 2022, followed them through 2023, in part to capture cost aims that we're not talking about here, but one of our aims was around cost. Next slide. And this is where we ended up. So we had almost 11,000 patients who were eligible in this study. Little over half of them were female, good distribution across age groups, about 6% Black patients, 3.4% Native American or Alaskan Native, 3% multiple racial or ethnic groups, 86% white, 3% Hispanic. About 58% of patients were eligible because they had an existing opioid use disorder diagnosis, 40% because they were high risk by that risk estimate, 2% because they'd had a recent opioid overdose. And lots of mental health comorbidity in this group, anxiety, depression, bipolar disorder, and 46% were insured by Medicaid. And what we found, we did not move the needle on opioid use disorder diagnosis in 30 days or mood maintenance over 90 days, but we did see higher rates of naloxone prescriptions. We basically doubled that. And then medications for opioid use disorder, either initiation or referral, higher in the intervention group, 14% versus close to 10% for usual care. So we were happy to see that. And I think next slide, even happier to see that for some subgroups, we had even more of an effect. So for our Black or African American patients, compared to white patients, we had more of an impact. So, there's a treatment gap there, and the tool helped start to narrow some of that treatment gap. Same with Native American or Alaskan Native patients. And same for patients who are high risk compared to very high risk. So that EPIC risk equation kind of buckets people into low risk, high risk, or very high risk. And our thinking here is that patients who are very high risk are probably already on the clinician's radar, where they may not have as much recognition of patients who are sort of in that high risk group, I didn't go over this in a couple slides ago, but it was about 80% of our patients were high risk versus 20% were very high risk. So I'm going to pass it back to Stephanie so she can talk about more of the mixed methods work that we did while the study was ongoing.
Yeah, so we called this work AIM 5, which was a lot of the work. But we really wanted to understand kind of the implementation of the tool and what were the factors that influenced that. And so we interviewed clinicians and leaders. Again, this is a different group of clinicians, primary care clinicians and leaders who had been a part of this trial. And we asked them very kind of similar questions to what we asked before, but more about asking about what are the things that influence whether or not you use the tool and what your perceptions of the tool were itself. Interestingly, we heard, we went into it actually thinking that the tool use was pretty low, and Rebecca didn't really talk about this, but the clicks into the EHR tool were actually quite low. So when we were trying to track use, the main way we track use is print rates, which are print rates, were in the high, 70 to 80% of encounters generally. It varied a little bit based on the health system. So we knew that it was getting printed, but then, when we wanted to know, were clinicians clicking into the tool, we didn't see very many clicks. So we're like, oh, are they actually using it? So that was kind of one of the concerns as we were in the implementation phase of this trial. We found out that clinicians actually preferred to minimize their conversations about OUD in general with patients. They felt it would kind of raise some uncomfortable conversations with patients. Again, kind of that relationship came up a little bit about like, yeah, I am willing to talk about it, but it is uncomfortable for sometimes to talk about opioids with patients. So they didn't want to talk about it very much. So unless the patient brought it up or unless they were really, there was a situation that made it necessary for them to talk about it, they did not want to talk about opioid use disorder. However, as Rebecca showed with our printout, we have this tool wizard, which is the clinical decision support tool, has been implemented here at Health Partners for a long time, and it originally was focused on cardiovascular disease prevention. And they love that aspect of the tool. They think that that's very helpful because that's a condition that they want to treat, they get measured on, if it helps them manage blood pressure, manage lipids, they're very enthusiastic about a clinical decision support tool for cardiovascular disease. But again, there was this lack of enthusiasm about wanting to address opioid use disorder. So when they just were not as enthusiastic, I guess, about trying to talk about this topic with their patients. And again, they mentioned a lot of contextual barriers in primary care that kind of limited their use of the CDS. Obviously, we were in the middle of the COVID-19 pandemic at the time, so that was one of the big issues that, obviously clinicians were highly stressed. There was a lot of turnover in the clinics, not just with the front desk staff or with the nursing staff, but also clinicians. And so it felt like everybody was new. They were retraining everybody. And so it made it hard to use a tool like this, which was supposed to be part of the regular workflow, where the rooming staff would actually be the ones that would print this for the clinicians. And so it just seemed like there was a lot of chaos happening. And again, kind of not really feeling like they had the support from their colleagues, from the other clinicians in the clinic to prescribe buprenorphine or to manage patients with opioid use disorder. It just felt like there were a lot of barriers to actually doing this in primary care. At the same kind of similar vein of what we heard earlier, the CDS really need to be simple. Like, give me the easy buttons. Those are the things that I look for. But it also had to be visible. So sometimes clinicians had a hard time finding the tool within Epic. So again, the printouts come, but then there's also a place that they can look in the EHR to actually kind of do the clicking. And so they felt like they didn't always know where to look for that. And so that was confusing. And then the other thing is that the CDS couldn't add time, but it also had to save them time, right? Because if it's neutral, it's not helpful. If it saves me time, yes, I can see that as being a useful tool. But it also has to help add value to care. So I have to feel like it's doing something for my patients. It's helping me provide better care. So it has to be valuable, simple, visible, and all of things in order to be useful. And so really where they saw the value in the clinical decision support tool was identifying patients who are at high risk for opioid use disorder or who need treatment, need something, maybe need a prescription for naloxone. And then, the opportunity to screen patients who they may not have thought about as being high risk. So kind of going back to what Rebecca mentioned is, that high risk group versus the very high risk group is just maybe a little bit more valuable because they may not have been on the clinician's radar. And we also surveyed our patients who we thought had received the tool. So these are patients that we knew had an eligible encounter where that printout was printed so that they should have seen that tool. We surveyed 127 patients. Average age was about 48, about half were female. And then we had a mix, about a third had a diagnosis of opioid use disorder, and most of those have some sort of treatment. Interestingly, less than half of patients recalled having a conversation about opioids during that encounter. So we said at a recent visit, but we kind of assumed, because we tried to survey patients really close to after when they had that initial encounter in the clinic. So less than half actually recalled having a conversation. And when they were asked who initiated it, about half the time the patient actually initiated that conversation. The primary care clinician about 40% of the time, and the nurse or the rooming staff about 9%, which is a little bit surprising, but it might have been come in contact or come when patients were getting that printout, like, oh, by the way, here's this printout about, mentions opioids down here. When they asked patients who should have conversations about opioids, again, a little more than half said that it should be the primary care clinician. And about 19% said it should be a prescribing clinician if that's not the primary care clinician. A few patients preferred specialists, so addiction specialists or pain management specialists. We asked a lot of questions about how having this conversation or getting these printouts made patients feel, because if you recall early on, we had feedback from patients about, don't call me an addict, use this language. We were very concerned about the different ways we were presenting this to patients. And so the good news is that, a lot of patients felt like they felt cared about. About 37% felt like just having this conversation makes me feel like my doctor actually cares about me. A quarter felt relieved, like that they're all like, great, we can have this conversation. A few were interested, and a minority of patients felt kind of ashamed. So which is the goal. We didn't want patients to feel ashamed or alienated about having these types of conversations, because ultimately we just want to open the door for patients to be willing to have this conversation. There were open-ended questions we asked about, like, tell me about how this conversation made you feel. Again, some positive things like, my clinician cares about me, open that dialogue, again, just feeling cared for and making sure that my doctor and I have a plan to work on this together. On the other side, we did hear some negative conversations, right? So some patients felt like having this conversation made them feel more concerned about their risk for having opioid use disorder. Like, I don't want to have an opioid use disorder. We heard a lot about this kind of tension between patients and clinicians about, willingness to prescribe opioids for pain. Patients feeling like they're having to beg for the patients or for their clinicians to prescribe these medications when they feel like they need them in order to manage their pain. Again, feeling like they're not listened to. So those were kind of the minority of the situations, but they did still occur. So we know that again, these conversations can cause tension, and we heard that from clinicians ahead of time. Like, these are not conversations I want to have, and we heard from patients on the back end, like, yeah, sometimes they are not fun conversations to have. So when we asked specifically about the handout, and that's what the example that Rebecca showed earlier, only about a quarter of patients actually recalled getting this handout. And remember, these were encounters where we thought everybody had it printed. So we limited the recruitment of the survey to everybody we thought had printed a handout, but only about a quarter of patients remembered getting it. And we asked them kind of, where did you get it from? Over half got it from the clinician, about 40% got it from the nurse or medical assistant. For the most part, our workflow is that the nursing staff or medical assistant prints it, and in each clinic, it's a little different. Sometimes they'll hand those materials directly to the patient. Sometimes they'll put it on the door outside of the room for the clinician to pick up. So it is vary a little bit from clinic to clinic. You can see here kind of just when they received it. We're trying to understand the implementation, like, how is this working? When do people get this? And again, these are only people that remembered actually having that handout. So there was a lot of variability essentially from clinic to clinic. However, when we did ask them, about did the handout make you feel more comfortable talking about opioids, over 80% said, yes, the handout makes me feel more comfortable talking about opioids with my clinician, having something here that we can like start a conversation about. Again, how did this handout make you feel? The highest rated response was it made me feel cared about. So that's we felt was positive. Again, the other emotions were kind of it didn't really matter, indifferent, redundant. A minority of people again felt ashamed. Some people felt annoyed having to get this, but it was a very mixed bag in terms of what patients felt after getting this handout. Same thing, we asked kind of an open-ended question about which, how did that handout make you feel? You know, some people again had positive things, like I felt lucky that I'm getting this help. I appreciate this information. Where, you know, again, annoyed. I'm always getting the same thing, like about my risk, and I hear it all the time. I don't need this in multiple formats. Or, you know, feeling labeled by their physician. Again, somebody, you know, being concerned about being labeled as somebody who has an addiction. All right, and I'll pass it back to Rebecca for our conclusions.
Yeah, thanks, Stephanie. So, you know, ultimately, just kind of summarizing that we had this cluster randomized trial of 10,891 patients across 92 primary care clinics, 3 health systems, and we saw improvement in rates of naloxone orders within 30 days and 90 days, and initiation of meds or referrals for meds within 30 days and 90 days. So, happy to open it up for questions and conversation.
That was outstanding. What an amazing piece of work, a true campaign across clinics and systems. My guess is that there are going to be some questions. I know a few people here are actually primary care addiction medicine providers, and others I know do research in the primary care space. So why don't I just open it up and see who wants to jump in? Well, I'll jump in just to make sure everyone knows the water is safe. Yeah, as an implementation person, I'm always interested in turning the microscope, if you will, on the providers and the clinics away from the patients, and not that the patients aren't of interest. And Stephanie, you did an amazing job with the qualitative piece, really trying to understand some of the perceptions of the providers and the teams and so forth. I guess I was wondering, with a number of clinics and the number of health systems and the number of potential providers, if you are able to take a look at different rates of adoption or different variation by clinic, and even if the goal, I think, Gavin, you talked about the structural barriers to primary care providers kind of jumping in to the addiction medicine game, if you will, if any of the clinical decision support was sort of enabled providers to jump in that hadn't been in beforehand. So if there was an increase in the number of providers who, you know, were addressing opioid use disorders or prescribing either naloxone or Suboxone, and if you saw that growth by clinic or provider, maybe that's a question I have.
Thanks, Mark. That's a great question. I think heterogeneity is the name of the game, essentially, in our clinics. Like, we know that across the clinics and across clinicians, there was a lot of different rates of adoption. We monitor like just the print rates, right, from different clinics. They vary across clinics. They vary within clinicians within those clinics. So we know that there is a lot of variability. And so I don't know if we looked at anything in terms of like the variability and how that related to outcomes with adoption. Rebecca, you might have a better idea on that.
Actually, that's in progress right now. So we haven't looked at that yet, but we are. But we did see big differences in print rates across clinics and across health systems. One thing I didn't get into here, but you know, we talked about at Health Partners, we've had this tool for a while, you know, the platform, the Wizard platform, focused first on diabetes, then cardiovascular risk reduction. One of the other sites had the cardiovascular wizard already in place, and so we could layer opioid wizard on top of that. The third health system had never seen anything like this. So really different starting points for these health systems that I think may have contributed to some degree to sort of print rates and use rates. Another kind of cultural factor that we don't really talk about, my health system, Health Partners, is pretty top down. You know, the leaders say this is what we're doing, and for the most part, you know, clinics adopt that practice. We had another health system, I'm not going to tell you which one, very much not like that. You know, they sort of were they're not as top down, and they sort of as they expanded, brought in different clinics that were sort of used to doing their own thing and didn't like this new structure. So really different cultures too that I think contributed to different print rates and adoption rates.
I had a question about kind of more focused on the tool. So it sounds like that, you know, it started with this other tool and you guys built onto it. Was that Wizard originally meant to be built onto, like, with additional layers, or was this just kind of like opening some brand new, can we do it? How do you get the intel to do that? I was curious a little bit about that, because, you know, there's so much direction that, you know, heading towards these clinical decision tools to try to help, you know, workflow and decision making.
So when Wizard sort of started 15 or 20 years ago, it really was focused on diabetes care. And I think that the breakthrough innovation there was figuring out how to have this web-based intervention, because it really is web-based, display to the clinician like it looks like is part of Epic, and have it integrated with Epic to have that functionality that I was talking about. And do it in a way that doesn't interfere with workflows. There was a lot of consideration. It's why we print it and ask the rooming staff to distribute it. We don't have a hard stop for the clinician workflow by design, because we don't want to start off by making them mad at us. We want them to use it. So that was sort of the innovation. And at that point, it was just focused on diabetes. I mean, I wasn't around them, but I don't think they were thinking ahead to what else can we do with this. But it became clear diabetes is such a major component when you look at A1C as a risk factor for cardiovascular risk, that was the logical next step for that. And then there was a gap, I would say, of 5, 6, 7 years where those were the only things that it was focused on. But we started thinking about, and actually it was Gavin connecting us with the CTN, where they're like, we've heard about this tool that can do this for cardiovascular risk. Do you think you could do this for opioid use disorder? So I think that was probably the first big foray into something that wasn't really centered on cardiovascular risk, and a lot of discussions about how we were going to situate this. You know, the whole idea of what we call Priority Wizard is for that patient at that visit, what are the priorities for that person? And that led to lots of discussions about how in the world do we prioritize these very different clinical domains. It was relatively easy when it was just cardiovascular risk, because you basically just look at the risk equation, you know, and kind of figure out what's the top priority for that person. Now we have wizards for chronic kidney disease, cognitive impairment. I'm forgetting some other ones, but, you know, pretty different clinical domains where we've written some decision support for depression. So lots of different domains, and that's trickier. But I think when we started, it wasn't thought to be as modular as it is now.
Thank you so much.
We'll just for the group, we'll do the work group reports by email, so we'll fill you in on those. This is a very rich conversation. I know Kurt, Dr. Snyder, you unmuted yourself, so I'm guessing you have a question or comment.
Yeah, thank you. I do a lot of work to try to get primary care physicians to do this work, and some of the barriers that we run into a lot of times is they don't want to be alone. Who do I have do my call? And then on the other side of that, they don't want to be the one that collects these patients. So I'm really interested in the way that this was system-wide. It kind of overcame that because there's a lot of people doing it. And I wonder if it would be good to compare to systems that didn't do this, because I imagine that you're going to see a change across all systems just because of the fact that more people are doing it, more people are willing, and you're going to locate your champions in that too. I mean, the medication is incredible, and you see people respond in incredible ways, and you'll build champions that way. So that I guess utilization rates, not just within the system, but comparable to other systems that aren't doing it, would be my thought. Thank you.
Yeah, I was honestly surprised when we started and we went to the care group and said we need a list of waivered clinicians, and they're like, we don't really have one. Just identifying that, and in some respects that was easier. Then when it became no waiver needed, any clinician could do this, we still needed a list of folks who seemed interested and engaged for that referral system to work. But we did hear those concerns early on. Like, I can prescribe this, but there's nobody else in my clinic who can, especially when the waiver was required. And so it's a mess when I go on vacation and I end up coming back to just a disaster. That was a real concern. And honestly, when we first started this and got the pilot funded, our care system was really nervous about becoming sort of known as the care system in town who would treat opioid use disorder when some of these others weren't yet. And so we had to navigate some of that too. But the pendulum sort of swung one way, and by the time we were ready for the big trial, had swung the other way. But yeah, those are real concerns, and I think it would be really interesting to look at some of these other health systems.
Well, Dr. Rossom, Dr. Hookre, Dr. Bart, awesome presentation. We actually didn't get to all the questions and comments, which I would take as a good sign. We know where to find you, though, so we'll assume that people, if they don't have your contact information, we'll facilitate a connection to follow up. But Dr. Vo, who's the acting director of this CCTN, recommended you, and I have to say it was an awesome recommendation. This is really important work.